Okay, so what I'm going to talk about is short stature diagnosis and management key insights from 2019 Growth Hormone Research Society Consensus Group. And the reason why I'm doing this is because I had the privilege of being part of this group of a large number of pediatric endocrinologists from around the world, and that's me there in that large group. But there are some very eminent people like Professor Michael Ranke, Andrew Dauber, Andrew Sinclair, Pinchas Cohen, and very many eminent pediatric endocrinologists from the world. So this group met in Portugal, in Lisbon, in March, and then this document came out with some new thoughts and guidelines about growth hormone and short stature. So let's move on. What I have done is that I have picked up about 30 important points from the article, and they will start after the first couple of slides. So the Growth Hormone Research Society, as I said, had a workshop in March 2019 in Lisbon, Portugal, and there were 46 pediatric endocrinologists and specialists in their own countries and field. And the writing team was formed, and a document was prepared as a Growth Hormone Research Society Consensus Guideline 2019. So let's start with some of the important points in the document. In the evaluation of children with short stature and or growth deceleration. So here the GRS first now tells us not only about short children, but children who have low growth velocity. That although the WHO growth charts can be utilized for children up to 2 years, local growth charts when available are more appropriate for older children. That has now been documented in the GRS consensus guideline. Then the next question is, which children should we evaluate for pathology? And it says that short children with a height SDS below -2, height that clearly deviates from the family background, or a significant decrease in the height standard deviation score, that is a deflection of at least 0.3 SDS per year, should be considered abnormal. However, a diagnosis of growth hormone deficiency does not require a height cutoff. Please remember this. This is a slightly different wording, I would say, particularly in the context of very young children. Children who are extremely young, they may not have enough time to show that degree of deviation even when they are growth hormone deficient. And those who have had hypoglycemia and or midline defects and pathologies, or a recently developed GHD, for example, post-craniopharyngioma surgery. You will have to wait for a year, as you just heard Professor Lars saying that. But there, the deviation is more important, the drop in the height velocity, rather than the actual height SDS. So that has been clearly spelled out. Then short stature that does not get normally adequately evaluated around the world, and they mention 3 conditions: familial short stature, short girls, and childhood cancer survivors. Often their short stature is not looked at very carefully by the health care providers around the world. And I'll tell you one interesting thing that I found out from my clinic is about the short girls. If you look at the number of referrals which are made for boys and how many growth charts actually I utilize for boys against girls, the astonishing fact is for every 5th growth chart that I use for a boy, I use 1 for a girl. So that is the frequency of referral for short girls, whereas the prevalence of short stature is equal in boys and girls. Then interpretation of a child's height and height velocity based upon his or her pubertal status reduces misclassification of children with delayed puberty as having GHD. Now this is particularly in the context of constitutional delay in growth and puberty. So rather than going by age, the society insists that we must tie it up with the pubertal staging. The use of sitting height to height ratio is believed to be more reliable and reproducible and is preferred over upper segment, lower segment ratio. So we in our country still continue to use a lot of upper segment, lower segment ratio, but in this year we have published paper on Indian children's sitting height and subischal leg length, and has been published and is available for you to download and use. And we must use not the upper segment, lower segment ratio, but sitting height subischial leg length, because it's more reliable to bring out disproportion. And now that we have national centiles for sitting height subischial leg length, I think we should be able to pick them up better. The laboratory test should be guided by clinical features rather than routinely applied to all patients with short stature. So don't throw a blanket. Go by your clinical judgment. Clinical discretion should be applied to the scope of testing, especially for non-endocrine disorder. Bone age is less helpful in children with obesity and in very young children, especially those who are less than 2 years old. A hand and wrist radiograph performed to assess bone age may also be helpful in identifying subtle signs such as skeletal dysplasia or any other pathology. For example, the other day I was doing a hand X-ray on a girl with precocious puberty, and I could pick up bony abnormality in the form of a bone cyst, and the child was actually proven to have McCune-Albright syndrome later on. So hand X-ray can be extremely useful when you're suspecting something like a skeletal dysplasia or a bone disease associated with short stature. So the society says that not only look at the bone age, but also look at the bone pathology. Advanced bone age in a family with dominantly inherited short stature may suggest newer mutations such as the agrican mutation, the ACAN mutation, where there is relentlessly progression of bone age leading to extremely short final height. Bone age may be advanced despite growth hormone deficiency in severe obesity, such as in patients with craniopharyngioma and hypothalamic hyperphagia. So your bone age may not always guide you for the diagnosis of growth hormone deficiency in certain conditions. Older bone age standards may not be applicable to all children. For example, the society says that the Grulich and Pyle standards, which are published in 1950 on Caucasian children living in one province of America, predominantly of the North European ancestry, if you are going to use that, then we need to have further work done as per the ethnicity. And there, as I said in my talk yesterday, that because Tanner Whitehouse 3 method has more Asian bones in it, it is more appropriate to use, especially in a country like India. The diagnosis of growth hormone deficiency remains a clinical one, where one synthesizes oxology, anatomic and laboratory data to arrive at a diagnosis. It should not be made based solely on laboratory testing, and I think the session that was before this session has thrown enough light on this particular aspect. A low IGF-1 in young children is difficult to interpret, and we discussed that during Dr. Supriya's lecture. So below the age of 3 years, I think we should use IGF-BP3 as a screening test rather than IGF-1. An IGF-1 level more than the 0 standard deviation score at any age makes the diagnosis of growth hormone deficiency unlikely. Now this is very important to remember. So if you have a stimulated growth hormone value which is actually falling below 7 nanogram, but you have an IGF which is nearly normal, it's less likely to be growth hormone deficiency. IGF binding protein 3 is considered a more reliable biomarker than IGF-1 in children who are under the age of 3 years. An MRI of the hypothalamus and pituitary gland should be performed in all patients diagnosed with growth hormone deficiency. Please remember this. You should not leave it out. To detect anatomical defects of the hypothalamic pituitary region, brain tumors, and other CNS disorders which may be associated. In one of our papers that we have published 2-3 years ago, we actually found abnormalities such as basilar impressions and cerebellar tonsils being lower than normal in children with growth hormone deficiency. So there are a number of anatomical abnormalities which are actually associated with growth hormone deficiencies and should be looked at when you make a diagnosis of growth hormone deficiency. Formal growth hormone provocation testing may be unnecessary if large cellular masses or certain pituitary defects such as hypoplastic pituitary gland, hypoplastic or absent stalk, or ectopic posterior pituitary is present. And there are other clinical features indicating growth hormone deficiency. So if you have got a kid who is clinically growth hormone deficient and you have got an MRI abnormality that suggests one of these pathognomonic features of growth hormone deficiency, the society says that formal growth hormone provocation testing may be unnecessary. Now please remember, this is in the context of a child with very severe short stature with a very poor growth velocity and clinical features of growth hormone deficiency. The finding of a small pituitary gland by itself, however, is not sufficient to make a diagnosis of growth hormone deficiency. So just because your pituitary is shorter than 5 millimeter doesn't mean that you can insist on a diagnosis of growth hormone deficiency. In neonates with high pre-test probability of GHD, a random growth hormone level below 7 nanogram per ml in the first week of life supports the diagnosis of growth hormone deficiency. Now this is something new for a lot of us, that in neonates with high pre-test probability of GHD, such as say a cleft palate, micropenis, hypoglycemia, and if you have a random GH which is less than 7 nanogram per ml in the first week of life, then it supports the diagnosis of growth hormone deficiency. It doesn't confirm, but it supports. A growth hormone stimulation test is not necessary when an alternative diagnosis for short stature is evident, such as Turner syndrome, Noonan syndrome, Prader-Willi, aggregans, Shock's deficiency, chronic renal failure, or Silver-Russell syndrome, or in children born small for gestational age with persistent short stature. So growth hormone stim test is not mandatory. There are no data to demonstrate that one GH stimulation test is better. Now this is a very important statement. We have always said that the ITT, the insulin tolerance test, is the gold standard, but there isn't enough evidence in the literature to say that any test is better than the other. Failure to respond to two provocation stimuli is needed to diagnose GHD, which limits false positive results, although it doesn't eliminate this completely. However, if there is a high index of suspicion, a single test may suffice. And I think that is added to that would be your oxology, your radiology, and your IGF-1 levels. No exact threshold was agreed upon for a confirmatory diagnosis of GHD based on the present data, but the majority of delegates suggested that the threshold should be revised to 7 nanogram per ml from 10, which is the common level used in America, whereas in Europe it's 7 nanogram per ml, especially because the testing is now monoclonal assay and it's not a polyclonal assay in most of the places in the world. There was a lot of discussion on sex steroid priming, and I will try to limit it to the least. Sex steroid priming may improve the specificity of GH stimulation test. Priming, however, has not been standardized in the world. The ideal age to recommend priming has also not been defined. Data are lacking regarding the need to adjust the cutoff for a diagnosis of GHD in patients who undergo sex steroid priming. Priming's efficacy in improving the diagnostic performance of growth hormone provocation testing in general is still unclear, and currently no clear consensus exists for the use of GH priming outside of the adolescence age where there is delayed puberty. So most people would agree during that meeting that except in the peripubertal period, there is absolutely no need to prime the child. Peripubertally, yes. Now, the group also wrote this nice little table, and I think one of the delegates had asked this question yesterday as to what, I think IPS only asked this question, as to what should we use for what type of short stature. And I wouldn't read this out, but you can go to the document and read it. As to whole genome sequencing is used when, whole exome sequencing is used when, single nucleotide polymorphism in which conditions, comparative genomic hybridization in which, and DNA methylation in which. I think this is very helpful for clinical use. The initial dose of growth hormone therapy for GHD should be guided by the severity of GHD. Now that's the new thing. So this is now moving towards individualization of growth hormone therapy. Patients with more severe GHD should be initially treated with lower doses of growth hormone, maybe as low as 15 microgram per kilogram per day. In such cases, a dose of 17 to 35 was suggested by the group. For other approved non-GHD indications, the doses prescribed may need to be higher. And the group recommended starting growth hormone at an approved dose ranges, possibly using predictions model to aid in the dose optimization. So I think this consensus actually is promoting use of growth prediction models for use in children even in non-GHD conditions where models are available. They are not available for every condition. In infants and adolescents, patients with obesity and those with Prader-Willi syndrome, growth hormone dosing may be based on body surface area rather than weight. So for Prader-Willi syndrome, for obese patients, we should use surface area rather than kilogram in calculating the dose. When using IGF-11s to adjust the dose, the ideal level of IGF should be close to 0 SDS in GHD. So in growth hormone deficiency, you are aiming just at a normal IGF level for that age. In non-GHD conditions such as idiopathic short stature, IGF-1 level of approximately +1 standard deviation or higher will be required. However, it is important that the IGF level is kept below the +2 SD in all conditions in which you give growth hormone as treatment. In certain conditions characterized by partial IGF-1 insensitivity, such as Russell-Silver syndrome or the receptor defect and Turner syndrome, IGF-1 levels above +2 SDS may be needed for effective growth. Now, this was discussed at length by the group, and that's a new thing because so far we have always said that keep them under +2. But the group said that in certain situations which I have enlisted here, your IGF level may go slightly above +2 SDS, and it was thought to be acceptable, and that has been written down in the guideline. Alternative therapy in the form of aromatase inhibitors in pubertal boys could be considered, but this remains controversial and off-label use of aromatase inhibitor. The use of GnRH analog to delay epiphyseal closure as a single agent to augment adult height is not indicated. Please remember this. It has to be with growth hormone. Adding GnRH analog to growth hormone therapy may be considered for children with growth hormone deficiency or SGA or other or Russell-Silver syndrome patients if height SDS is low at the onset of puberty. Whether the treatment was started before puberty or not is immaterial, but at the onset of puberty, if a patient is much shorter, consider adding GnRH analog or aromatase inhibitor. Now, there were some future directives, or let's say wish list, which was given by this group. Alternative therapy in the form of aromatase inhibitors in pubertal boys could be considered, but remains, in what's new, Masimorelin, a ghrelin agonist that provokes GH release from the pituitary, was recently approved as a diagnostic test for GHD in adults in America and Europe. Advantages of this stimulant includes oral administration, requirement of fewer blood samples, presence of fewer side effects, and most of the provocative agents, high sensitivity and specificity, and greater reproducibility than other stimulants. So that is an agent which in future may be used as a growth hormone stimulant in pediatric age group. Now, in treatment, oral ghrelin analogs, such as what I have enlisted, are likely to be useful in children with severe pituitary form of growth hormone deficiency, but may have potential in children with hypothalamic GHD or milder degree of pituitary dysfunction. Instead of growth hormone we are talking about. They may also be effective in non-GHD children with low BMI, such as Russell-Silver syndrome, idiopathic short stature, SGA, and Noonan syndrome, given their orexogenic effect. Because as you know, a lot of children with Russell-Silver syndrome, when tube fed while on growth hormone therapy, grow better. So agents which improve your appetite may have a separate role in conjunction with GH or without GH therapy as well. Now, C-natriuretic peptide, the CNP, is expressed in growth plate and is an important regulator of chondrocyte proliferation and differentiation. And CNP analogs bind to NPR2 receptors, interfere with the downstream FGFR3 signaling cascade, and are under investigation in achondroplasia. Can I just have 2 more minutes?
You have 3 minutes, 3 minutes.
Okay. FGFR3 is mutated and constitutively active in achondroplasia, hypochondroplasia, and associated skeletal dysplasias. CNP analogues may be theoretically useful in these conditions. Now, future directions for research, these are my last two slides. The society felt that the international standardization and harmonization of growth hormone and IGF-1 assay, as assay variability can impact these measurements. Guidance regarding the ideal GH stimulation test, including evaluation of newer agents such as massimorelin, standardization of GH stimulation testing procedures, establishment of diagnostic cutoff for GHD at different pubertal stages. Now that was something discussed at length, that we use that 7 cutoff at all stages, but in puberty, should you have a higher cutoff? Investigation, or should you have a higher cutoff when you prime somebody? That was again discussed, but there was no consensus on that. Investigation of the impact of obesity on the diagnosis of GHD in children, type data on rarer genetic causes of short stature. This could assist in establishing new diagnostic and treatment strategies and facilitate a personalized approach to the evaluation and treatment of children with growth disorders. So that was the wish list of the group that had met, which has been put down in the document. So with that, I thank you for your patient listening, and I hope that I have added few more points and a lot of food for thought for you to think about. Thank you.